infections, diabetes, and cancers rise steadily, reshaping morbidity and mortality across the continent. Now, these parallel pressures are testing health systems. In this edition of Hot Issues, we explore questions of preparedness, early detection, workforce capacity, and governance, which are now central to discussions about resilience. I am Kemini Amano, and in this edition, I sit down with the WHO, during which we focus on how these challenges intersect, what progress has been made in strengthening systems, and how Africa can better anticipate, prevent, and respond to the next pandemic while addressing the expanding burden of NCDs. My next guest is Regional Director of the World Health Organization Regional Office for Africa, Dr. Mohamed Janobi. Doc, welcome to Hot Issues. The Accra Initiative. What has changed since the summit in 2025?
What has changed? It started as a local thing to Ghana. Then it sounded as if it's an African thing, but now it's an international.
What does that mean?
It means involving partners outside the continent, Gavi, Global Fund, Rockefeller Foundations, and others. So it's an African thing. It's African challenges with African solutions. Where the Accra research does not import things. Every 47 member states has got its own priorities. The challenges in Seychelles is cyclone, maybe. It's not a challenge of Ghana.
I see. The Accra Initiative is based upon the concept of self-sustainability, in that we want a sovereign health system for the African people. So in seeking those partnerships from the likes of Rockefeller, how differently is Africa going into those partnerships?
To me, it's very obvious. Rockefeller doesn't come with, okay, we are bringing money to treat UTI. Is going to be our partner in our priority. So if country A, the priority is tuberculosis, we go partnership in tuberculosis. If another country, its challenges are HIV AIDS. You know, if you recall what happened last year, when there was, the beginning of last year, when the ODAs and our biggest partner, US, withdrawing its cash, most of our countries were affected. Why? Because those vertical programs, they all relied on funding from donors who came, this money I'm giving you Ghana is for 1, 2, 3 earmarked, we call it. But this time around, is each country, let's start with the Accra reset, it started here. Ghana is going to show its priorities. Then we partner, not the other way around.
Are those structural reforms the WHO is making?
WHO doesn't make. We follow what are your priorities and we support. I'll give you an example. Since this thing came out, we deployed technical mission to begin assessment, dialogues, and planning for the national authorities. We have brought technical people on the ground. So my visit actually is trying to show, we are trying to translate that political vision of the president with fully aligned operational realities. So on the ground, and to reform WHO commitment, we follow what is the transformation agenda Ghana has.
Okay. Is this the first time the WHO is doing that, working within the framework of what a country requires?
It has been working like that all the time. We are emphasizing it this time more, moving it from the papers to implementation.
To implementation.
Yeah. And with the changes which we have seen, the world is evolving. Things which are happening today, I can never, only 2 years, I don't have to go far, could have happened.
Practically speaking, for the ordinary African or the ordinary Ghanaian, what will the implementation of the Accra Initiative look like for them in receiving healthcare?
I think it's going to look very different if the support and awareness is brought to individuals. Those who cannot, because you see, health is this way. It's not only accessibility. Is it affordable? So if you look on the whole concept, is allowing each and every Ghanaian to get a right to accessible and affordable quality healthcare. It's not only to get, you go to a health center, half of the things you cannot get. You go to a bigger hospital, yes, they are there, but they are not affordable. So this is the whole idea, to allow not to leave anyone behind.
If someone challenged that assertion that this is the same thing WHO has been trying to work on for a long time, and that, you know, Accra Initiative will not be doing anything different, what would you say to that person?
I would really request that individual or that community or that society, the evolution which has happened since beginning of last year, I can say. Do we understand what does it mean, reduction of overseas development assistance by 40%? Do everyone understand withdrawal of our biggest supporter, the founder actually, one of the founders of WHO, means what it means this time around? It's your problem, Ghana, solve it. PEPFAR money is gone. UNAIDS is on the sunset. What will happen? I go around, I just started my 7th month. I go around, I listen to ministers, I listen to head of states, I talk to healthcare professions. What has happened? The health budget has gone up. It's innovative domestic financing. Many of our countries didn't depend on this. For the first time, it has never happened like this. You know, WHO is run by 2 ways. You have assessed contribution, member states have to pay. And you have voluntary contribution. Now, if you look at it, assessed contribution is less than 20%. Voluntary contribution is 80%. If it was a private business entity, do you know what a partner of 20% and 80% means? You are the minority. The majority will decide how we are going to act as a company. But what happened this time around, and I really thank Tedros, our DG, convinced the countries, talked with the countries. Our assessed contribution has gone up. There was first installment already, second installment 2027, and third installment 2031. What does this mean? It means WHO is going to be more independent. The countries are going to be more independent because we are going to, our capacity to assist, the technical normative capacity is going to be even larger. Despite all these things, and that's why WHO, what we did, despite all the shakes, our presence in 47 member states is still there. We are everywhere in Africa. There's no single country we have left behind.
I see. Do I glean from what you're saying that despite the shortfall in funding, not only did the WHO pull this weight, but African governments also did to fill up the gap?
Exactly.
I see. Now, I want us to, because you brought the issue of funding, let's stick with that. The US has formally withdrawn, obviously, the WHO has reacted to it, but practically speaking, what would its impact be? Or what should its impact have been on the African continent?
Okay, well, specifically you want to talk of Africa, but the entire WHO, wherever we are, as I said, we have 100. I still count the US, still our member.
Why?
The reason is we are going to have our board meeting next week. So it's not a decision of WHO, it's a decision of member states. But our executive board is going to meet next week. And that's why from here tonight I'm heading to Geneva. I will say I will restrain to discuss the departure because the only time it can happen in when the board meets, I've already listened to the member state, the decision is going to be. So next week, lowering the flag does not translate to you've quit. There are a number of things.
But they're already holding back funding. There is already arrears that have not been paid to the WHO, which means that there is impact already being felt.
Yes, I have to say two things. Do we want US to move out of WHO? No, not only WHO, all other agencies which are under UN. When we say nobody should be left behind, it means we have to work, the entire member states to be working together. But let me come back to your specific questions. Last year, we had a strike of Ebola in August in Democratic Republic of Congo. For the first time, that was the 16th one. WHO working together with the government of Democratic Republic of Congo, other UN agencies, other non-UN agencies like CDC Africa. We controlled the Ebola in 60 days. It's a record. We reacted fast and we brought it into control. Ethiopia, 2 days ago, they had an attack of Marburg. We brought it into control. You know, I'm talking countries which the population is millions. Small island development countries, SIDS we call them, Seychelles, Comoro, Mauritius. They eliminated 2 major viral diseases, measles and rubella. So, despite of these shocks, we are not stopping. And I'm telling you, we're not going to stop. We don't have much of a choice. We can take, it has shown that the question is, how can you do better with less?
With less.
Yes. So here is just smart spending, very thorough planning, picking priorities, And WHO is doing the same. Pick priorities which can have an impact. You can have a millions priority. But we talk with our member states. Pick priorities which can make an impact.
So what are the priorities now? With less funding, what are your priorities? In terms of WHO Africa, what are the priorities?
We want to see local manufacturing of medicines and therapeutics and devices, especially vaccines. Africa imports 99% of its vaccines. For health security, is not good. We want to see universal health coverage. No one should be left behind. You start with high blood sugar. It takes 20 years before you get diabetes. So if I invest here, I can pick somebody with high blood sugar. I can pick somebody with insulin resistance. I can pick somebody with pre-diabetes. So we have an allowance. Whoever creator you believe says, okay, I give you space. We want to combat antimicrobial resistance. Is a slow motion pandemic. Let me simplify it for your viewers. Just 10 years ago, maybe 15 years ago, when I was still actively practicing, how long did I used to treat UTI, urinary tract infection? 3 days. Today, I'll give example of women. 3 weeks, 5 weeks, I've been using antibiotics. Why am I not getting cured? Another one tells you, I used it last month. Why this month again I put UI? The bacteria have become resistant. I'm a heart specialist. I used to perform heart interventions, they call surgery, to simplify for you. I delay patients now in ICU after operation 3, 4, 5 days. The wound where I did an incision is not healing. Why? Because the antibiotics we are giving, someone I expected to stay in ICU 1 day, stretch out 2 days, now stays for a week, stays for 2 weeks. Now, keeping someone in ICU, the ICUs I know in Africa, the minimum is about $700, $800 a day. We wish to see we control communicable, non-communicable, and neglected tropical diseases. We need to increase our health manpower. So those are the sums of major priorities for WHO. Now we go down to the countries. And my 6.5 months experience in Africa, I've already been to 12 countries. Every country you go, it's just a matter of priorities. And of course, the other one which I shouldn't forget is climate change. They align with countries, but it depends which one. If you go to Mauritius today, their first priority is non-communicable diseases. Mauritius has got 800,000 cars. You know what is the population?
No.
It's 1.3. So if I remove the children, Mauritius has got a ratio of 1 to 1. Everyone has a car in Mauritius. So now they are struggling with non-communicable disease. That's their priority. And we are working together with Mauritius. The government there is very committed to see how it can. They've got the longest lifespan in our continent, 70 years. So you have this aging population. Fertility is down. With NCDs, roughly they are going to lose in another couple of years about 900,000 people. Now with a population of 1.3, and people are not having babies, the population is growing. Mauritius is one of the countries in Africa which has, the SDGs. They are just left with one. They are doing very, very well.
I see.
So their priorities, but if you go to, let's say, Another country, their problem is outbreak of cholera. Another country, their priority is building factories to manufacture. So Africa is diversity.
It's varied.
Yeah.
It's very varied. But and again, just a reminder that will come to the issues of disease burden, particularly the NCDs, as well. But while the WHO is working to empower countries, ensure that these countries not only are self-sufficient, but also are able to own their health systems. We know that the US is signing individual country agreements with at least a dozen countries on the continent. At least you have mentioned at least one of those countries, Ethiopia. How does WHO Africa feel about these independent agreements that the US is signing, we could say behind their backs?
Let me clarify one thing first to make, because I know there's excitement about this bilateral. Bilateral engagement has been there since the beginning of time. In many, many, many areas, whether be it medical, be it health, it has been there. My stand is for countries to see what are we having on the table with organization like WHO, what are our priorities, and my only thing I can say, because these are independent sovereign countries, WHO will never go and tell you don't sign. Actually, we are not involved at all. The thing which we can say, just read the MOU.
But practically speaking, especially in countries where issues have been raised about aspects of the agreement. For instance, in Kenya, there's a matter in court about the data transfer, right, and the data rights of the people, and the transfer of pathogen, and for some people not getting a reverse benefit, right? Practically speaking, if country A, member of the WHO, signs an agreement with a bilateral agreement with the US, there is pathogen to be sent. Do I send it to the WHO? I send it to my bilateral agreement. Do you see that conflict coming up in the future?
Madam, I am a regional director of WHO, but my background, I'm a scientist, a clinical researcher, and I've been an administrator, and I've been advisor to head of states. I will come back, when I come back to Ghana one day, I will comment on this. And why am I saying this? I have not seen the MOU, so I don't want to speculate.
I see. Does WHO Africa have any concerns that there could be conflicts in the future with these bilateral agreements that individual countries are signing with the US?
To have concern, you have to know the contents.
And so
I have to know the contents. When I read the contents, then I'll say, oh, I'm concerned. Oh, this one, bravo. So
at this point, the WHO does not have any concerns yet?
No, WHO Africa, let me say, and I say globally, that concerns will raise when you know the contents of the MOU. Because simply, and I'm not trying to avoid the question, let me tell you, I know there are 15 countries which were not. So the first question, I might just ask myself generally, are all these 15 same? Or they're different? Or two countries have been given the same, the other countries have been given. So I say, I really promise you, and no country has approached, at least Afro, that please, we have an MOU, can you read it and give us, so I will really say, can we move to the next question?
We will. Let's talk about the disease burden. You've raised a lot of concern around non-communicable disease, but why are we seeing such a rise? Here in Ghana, they say 45% of our deaths is attributable to NCDs. What could be responsible?
Lifestyle. Lifestyle. I, like many other African kids, when we were little, we will run to school. In school, we are in class, during recess or break, we'll play football. Asante Kotoko, that side, there are 40. The other team, this side, we are just running. When you go, you run back home. You change your clothes, you go outside and play with your friends. My kids today, if they're not picked by a school car, they are picked by a private car from home. When they come back from school, they've got the PS5. Literally, they don't need, I know, including my kid, he can play, he's in Tanzania or he can be in Accra and play with a kid who is in Belgium or in Europe. You just need a PS5, connectivity, and you are done. So we've become less active. Now, forget about the kids. We adults, what has happened to us? Now we can, most of the people, they start to manage either a motorbike or a car. A place where we used to go for walking, now we use the car. If we decide to use the commuter buses, they are stuck in traffic traffic, inactive. Look at our, and this one I should clarify very much. Fast foods, and sometimes other countries call junk food. Let me use fast food. They are everywhere. You know why? They are cheap.
Right.
So whom will be more affected? And this is something which sometimes it affects more. I am using the word more and less to the upper class. It's cheap. Somebody who is in super high class, he's got a choice. I'm going to eat avocado salad. So obesity has gone up. I've been CEO of the largest hospital in Tanzania, Muhimbili National Hospital, 2,400 beds. You pass through the labor ward, babies are 4 kilograms, and everybody says, mashallah, very good, bravo, the baby is big. No, it's not big. Yeah, no, it's not healthy. The baby is obese.
Even for babies?
From day, madam, you know now we have clinics of diabetes, a 9-year-old. During my medical schools, unless you have got type 1, which you are born, you have inherited, there was no type 2 diabetes for children. And that's why even we have changed our terms. When I was in medical school, there was type 1 diabetes, which you are born with, and type 2, it used to be called adult onset, 18 years plus. You know, internationally, in late 90s to 2000, we have removed adult. Now we say type 1 and type 2, because 11 years old, diabetes. 9 years old, diabetes. Now, try to see how can the difficulty you have put this child at the age of 9 to use medication, literally, if doesn't follow change of lifestyle for the rest of his or her life. And that's why 70% of premature death happen in our developing world. When we say premature death, is you die before the age of 70.
I see. So as we are trying to build new systems, what would be the solution to NCDs?
Lifestyle change.
How should the systems incorporate that? Because building the hospital alone will not deal with NCD.
Yes, it will not at all. And I don't advocate that. As a physician, let me leave my position behind. We are encouraging member states now, and it's part of my manifesto. Take NCDs, put them in primary health care. Because I said earlier, In primary healthcare, in the, dispensaries, they can pick high blood sugar. High blood sugar is not diabetes. These are two different things. If I give you a kilo of honey to drink now, if I measure your sugar, it will be high. But you're not diabetic. So meaning, if community health worker pick a high blood sugar here, very early he can refer to the next level of referral so that they can do more tests, and without putting a single pill, reversing that condition. Because what will be the directive if it was my patient? I want you from today to walk 10,000 steps, which is about 6 kilometers. I want you to drink enough water, 1.5 liters. I want you to eat fruits and vegetables. I want you to stop, if possible, and it is possible, alcohol and tobacco. You're done. Actually, my approach is free of charge.
I see.
If we depend on tertiary hospitals, meaning, please, we warm up, we are just waiting for you here. When you come to us with kidney failure. Now let me tell you, if you get a kidney failure, you need dialysis 3 times a day, 3 times a week. And dialysis, madam, is not treatment. Dialysis is a bridge to kidney transplant, which in my country is $40,000. Dialysis, $150. Now, if you have 3 sessions, that is 450. Do you want to multiply it by 1 year? How many can afford?
Very few.
Yes. You talked about outbreaks. Let me be precise with you. Last year alone, as a regional director, we had 114 outbreaks: Ebola, Mpox, polio. Now I'll just pick one. Out of last 9 outbreaks in this world, since way back, Spanish fever, 7 of them are related with animals. They're called zoonotic. Population has increased. We have encroached human beings to the forest. Those were not our habitats. Those were animal habitats. They've got their own viruses which they can deal with them. So we have gone there, like Ebola, we've picked the viruses from them.
Does that have a solution?
One, when you hear, let's say, I'll give you first a simple example so that you can see how I connect. When you hear there is cholera, which ministry will you blame?
The health ministry.
You see, that's the perception. It's wrong.
Why?
Does Minister of Health does water supply in Accra?
No.
No. Does Ministry of Health do city planning? My point here is a multi-sectorial. When you hear cholera, Minister of Health is involved, Minister of Planning is involved, Minister of Local Government is involved, Minister of Water is involved, and Minister of Finance.
Do you find that that is how African governments approach public health developments like cholera?
We are trying to bring that awareness. When you hear there's Ebola, whose problem is that? Who is dealing with forest? Is a minister of either forest in some countries, sometimes agriculture. You have Minister of Tourism, people that have tourism. You have got Minister of Agriculture. People are going to they are farming to the new areas. Minister of Health. So the point here, these problems are multi-secretarial, multi-ministerial. If they are not approached, we even came up, WHO, with a term, One Health approach. And like cholera, we call it WASH, because there's water, sanitation, and health.
Right. When we look at the amount of effort we've put into public health developments like cholera, And over the last 2 years, we've seen huge outbreaks of cholera, for instance.
15 countries, as I speak.
What does it say? Is it that the investments we are making are not yielding, or the African leaders are not putting their money where their mouth is?
No, let me put it correctly. Not correctly, but the way I see it. We are encouraging member states to go with how fast this world is evolving. The urbanization, the migration of people. But you have country X still has the same number of latrines it used to have maybe 30 years ago. Country Y, it has got the same water pipes it used to have just before independence or just after independence. So we as WHO on public health, we are advising we have to move with a real time and take actions with real time, do education at real time, because I visited country Y. With the migration, the people of that village, culturally, they don't use toilets, even if they're there. They usually believe in using outside. So maybe you and I will think, oh, it's primitive. No, it's not primitive. It's a culture. Now, when this person moves to town and continues that culture, and there is a water source nearby, what do you expect? So I believe strongly we should continue. It's a marathon, it's not a 100 meters race, on educating, public education to our people. In WHO, we are giving a lot of pamphlets. We fund a lot of these awareness programs just to combat. How many people do know that, including yourself, that you can find polio on a septic tank? It's called environmental polio. So I continue, and the rest of my team continues to continue. Prevention, as they used to say before even I was born, is better than cure. I think now I know the meaning of it than ever. It's cheaper.
I see. When we come back, we'll continue the issue of disease burden on the continent and our response to it as well. This is Hot Issues. I'll be right back. Don't go away. Welcome back. It's still Hot Issues here on TV3. Doc, thank you so much for sitting down with us. While we're on the subject of cholera, what do you say to someone who says, look, instead of dealing with the primary problem, which you have excellently explained, now we're giving out vaccines to some countries, like Ghana, we are choosing the easy way out. What would you say to that?
One, I don't think giving vaccines is a shortcut. These things need to go in parallel. The health education to the population, universal health coverage, primary health care to have building more capacity with community health workers, and the vaccines is a combination. And just to make it to make you understand better, during COVID, people were given vaccine, but they were not told those who are given vaccines don't wear a mask. Those who are given vaccine, now you can organize Accra Hearts of Oak and Asante Kotoko to play. So these things were going in parallel. So, but what I'm saying, let's go to the root of the problem. And this is open, you can check with your internet. 2023, the US used 2.3 trillion on health budget. If you spread that one, it's about $12,000 for every individual in the US citizens. But what happened? I think it's one of the leading countries with obesity and overweight. It's a leading country, people dying of heart diseases. It's a leading country, people dying of diabetes, and I can go on and on. Why? Because they're not treating the root of the problem. They're treating symptoms. Because if you give a health education to a healthy food, you don't wait to get complications of obesity and overweight, which is very dangerous, I should say. Now we have imported so many things from the northern globe, but we have decided to import even the lifestyle. As I speak today, Africa, 32% of our population is either overweight or obese. Do you know what that translates to? 500 million people plus. That's why I'm saying this, if we don't do intervention, it's going to cost us massive. The quality of life, and this message I should give to Ghanaians and the rest of the, you see, when everyone is struggling, I'm saving for the future, my pension, the best pension, invest on health.
I want to stay on the subject of vaccines, right? Because then you had mentioned earlier how, as a continent, and even as, you know, a regional body, WHO Afro, you should move faster. One of the things we experienced in the last 2 years, even in the case of Ghana last year, is the slowness with which vaccines reach us. For instance, Malawi, a case in point, during the cholera outbreak there, it took a bit of a time for the vaccines to reach that country. In Ghana's case of the Mpox, it also took us some time to get the vaccines. What is responsible for that, and how is your tenure changing that?
We are in Ghana, and what happens in Ghana should go outside Ghana. Are you expecting me to stay in Ghana? No. I was here, and one of the complaints I had, the delay of vaccines. Actually, they came 2 weeks later. But it was more of logistics. The supply chain, the cold chain, the procurement process caused all those things. And I don't see them being resolved just like that overnight. And this brings me back. I had an opportunity to meet President Mahama and Minister of Health. The question of Africa importing 99% of the vaccines should be taken very serious with Afro member states. It's quite different if these vaccines were produced by Gambia coming to. Quite different if these vaccines were produced in Burkina Faso coming here. The distance and everything. So it's something I'm grateful most of the member states, including Ghana, put it as a priority of the country, and WHO, we are there to assist. Should be if we want to solve the problem. And while we are preparing, each member state in Ghana would ask, how much are you prepared with the cold chain? Because I can bring the vaccines in Accra. Can they reach the other side of the country? Because bringing the vaccines in Ghana is easy. The infrastructure, the airport and everything, where to store them is okay. So I really encourage you to look, how is our cold chain? How is our supply chain? And things like those. And WHO will always be here to do its normative technical assistance.
With that said, are we pandemic ready as a continent?
I can say we are ready. And I don't say theoretically. I've given you two examples from, let me start with DRC. The thing happened in Molape, in Kansai province. The nearest town was only 300 kilometers. Kinshasa is reachable. It's just by road 5 days because it was a rainy season. I'm sure it's about 3 days in normal circumstances. The population of Kinshasa now is running to approach 30 million people. The population of Kinshasa is half the population of Tanzania. But we contented it there.
Yeah.
What happened in Ethiopia is only 900 kilometers. Ethiopia is huge. If we were not prepared, and Marburg touched Addis Ababa, Ebola touched Kinshasa. And this is why I'm saying, when we talk of health security, when it touches such cities, it's not a problem of Congo anymore. It's not a problem of Ethiopia anymore. It's a global problem. We all recall what happened in West Africa in 2014. Liberia, Sierra Leone, and Guinea. The Ebola hit town. What happened? I was not in WHO at that time, but I went as a technical advisor to President Kikwete of Tanzania. He was a chair of that organization, to go and look what happened, why over 12,000 people died within a year of Ebola being there.
I mean, so clearly lessons have been learned to the extent that post-COVID, the World Health Organization decided to put together a pandemic agreement.
Yes.
And you have given us examples that even as a continent, we are pandemic ready to contain whatever.
We are ready, but we continue to improve.
We continue to improve.
Yes.
I see. Should we expect pandemics in the future in terms of the WHO's knowledge sharing of pathogens?
100%.
How
It's just when, and that one I can't predict. But will it come again? 100%. It's just a matter of time.
I see.
So this is what we are doing. We are building surge teams. We come to Ghana, we train, we do everything so that when it happens, you don't have to call people from outside. They will come just to fill gaps here and there. This is what happened to DRC. This is what happened to Ethiopia. They did it themselves. We just, when they put some technical stuff there just to help. So if we can manage, and this is my biggest dream before I finish my term, if we can manage as WHO Afro you know very well, not to give people the fish, but to give them the fishing rod. We'll be ready because I'm telling you, these epidemics, they will come. The pandemics, they will come, 100%. They came way back before these countries got a Spanish fever happened. Even Ghana didn't know when it's going to get its independence. They are still here today.
I want to talk about immunizations. The WHO started big catch-up post-COVID. How is that going?
To be honest, it was going well, very well actually. But what happened last year with all this financial shift and everything, it's shaky. The funding which we were depending from northern globe, you know, with obvious reasons, with war going to Europe, war going to the Middle East, these countries have got their own, the relationship of between North Atlantic and Europe. The priorities have changed on donation. So all the agencies, not only WHO, Gavi, which is shaky on its replenishment fund. So again, I come back to my member states in Africa, the governments which have employed me. I work under the ministers, and to this domestic financing, innovative, it's very crucial.
How much funding did you lose for immunizations for the continent?
I don't have the accurate number. It's shaky, but it is. Our biggest concern is WHO now, Afro. We made a lot of strides ahead, a lot of gains, and we have to be careful, otherwise it's... and these things have got spillover. Measles, when Senegal got 2-3 months ago, when they had a strike of Rift Valley fever, it spilled over to Mauritania. The Chad basin, we know what is going on with polio. Nigeria, the Horn of Africa is affected very much. The wars in Afghanistan is affecting us very much because it triggers down there, comes from Somalia and others until it reaches us up. So we work very close with our WHO organization in that area. It's called IMRO, East Mediterranean. This is why multilateralism cannot be substituted with anything. We need to share information. What is happening in your country? What are you doing? It gives us a lot. We also, well, Africa, we try to stick on the pandemic accord, which is going to speak on IHR, which is very important. Did some amendments last year. The big and important thing I want to leave to you and to the people watching us. In reality, when we talk about no one is safe until everyone is safe.
I want to come back to the issues of the vaccine, right? Which vaccines were shot because of financing constraints?
I think it doesn't have which one, and I mentioned 1, 2, 3, 4. The biggest effect started last year. We still have vaccines. The question should be, what will happen when we are going to receive now less vaccines? Because the financial year of most of these organizations, biennial like ours, just started January 1st. So it's a question that ask me a year from today and see what will be its effect.
The enough vaccines that we have will last us a year. Is that what you're saying?
No.
With full complement?
What I'm saying, a year from today, I will know the countries. We would have done the analysis. How many kids have been affected? That's why I'm saying 1 year from today. I'm not sure if you are expecting me to be here next week again.
No. So the only way to avert that, the possibility of a vaccine shortage, is more funding.
It's a yes and no again. Let's say I go to a country X. I have all the vaccines in the capital city. Let me give an example which is not true, but just for you to understand. I have all the vaccines in Accra, and north of Ghana, there are ethnic group fighting. Serious fighting. How are the vaccines going to reach there? This brings me back to the last few minutes. Always my Director General says, peace is the best medicine.
Away from the vaccines, let's look at HIV and AIDS. In countries like Ghana, we are told that there is a surge in infections, or the infection rates, so to speak. What does the WHO think is responsible for this, where we are seeing a rollback of all the good things that have happened in the past?
You are quite right, and let me not give a specific because I don't have the details of Ghana, but let me not mention when the Americans removed the funding in not only WHO, they've done it, UNESCO, UNICEF, other organizations, they will disappear altogether. UNAIDS is on the sunset. PEPFAR funds is no more. Most of our member states, they were depending on PEPFAR. It was fully funded by PEPFAR. Now, when you remove the funding, you know what happens. If you have an HIV and you are on medication, it means inside your body, the viral load has gone down, so chances of transmission to another person is minimal or zero. Pregnant mothers were given, so chance of transmission, maternal transmission was low. Now, I repeat, let's say country X, there's no that funding, but the economy is good, they will buy. But this country Y doesn't have that capability. Meaning what? The viruses will start to multiply again, the rate of transmission will go up again. So we are encouraging governments. This domestic health financing is very crucial. But at the same time, we are trying to encourage our member states to talk with the Northern Globe. The amount countries are spending in furnishing the loans, the debts they took from the Northern Globe. If you combine the budget in some countries, you combine the budget of health and education, and you compare how much they are paying back because of the debt, it's massive. So what I'm asking our Northern Globe, let's discuss, and we encourage member states, not with WHO, but with member states. Let's discuss. Ghana, can you discuss with World Bank or wherever you took a loan? Can we do debt for health swap?
Why is PrEP not widely available on the continent? Is it a case of a lack of domestic funding, or the world is just neglecting the continent?
It's a difficult question. And I think there is no one who can give a universal, but what I can advise, why I'm saying no one will give you an universal, the budget of medicines in Ghana is quite different from Nigeria. The Nigerian one is quite different from South Sudan. Every country has got its essential drugs. So it can be lack of money, it can be just priority. If you go to an area which malaria is prevalent, why should they put HIV drugs on the top of the list? They'll put malaria drugs. I come back, is it the problem of the West to neglect us? Madam, this is the mindset which we have to change. You have high rates of HIV in country Y, and you depend the neighbor to come and help you? Why don't you increase your domestic financing? Why don't you look on your drug list and say, okay, let me change. This problem has got a problem of hookworm. We have to get more drugs of hookworm. You go yourself, you check. There was one time when I was in Tanzania, We went to, I think it was Kilimanjaro. Let me give an example which everybody knows. Kilimanjaro is a very cold place. Why do you go to their stores, this is hypothetical, and find a lot of malaria drugs? They are going to expire there. Why those drugs are not taken to an area? So Ghana can again do the same in all the member states. How is our medical stores department, how do they distribute the drugs? How do they do their projections?
Right.
Yeah. So it's something deeper.
Thank you for talking to us.
Thank you.
This is Hot Issues. I'm Kemini Amano. There'll be a playback of this interview on all our social handles, including YouTube. I'll see you same time next week. Bye-bye.